Well, it's a real honor, and I'm quite humbled to have been invited to give this lecture. It's really nice to look out and see some people that have mentored me along in the audience, and if I haven't said it before, thank you guys for teaching me how to take care of sick people. Disclosures, I don't have any financial conflicts, and despite the heavy nature of this talk, I still like my job, and I feel fortunate to get up and go to work every day. Taking care of sick people really is still an honor. And despite this talk, I think most of us still feel this way. So let's have a few objectives. This is going to be a brief talk comparatively. We're going to try to define what burnout is, try to get some language around that we can use to discuss various issues. We'll attempt to describe the scope of the problem, and then we'll try to find some risk factors and on the other side some protective factors as it pertains to burnout. And finally, we'll outline some novel strategies for prevention and for treatment, and we'll divide those in what we can do individually, and perhaps more importantly, what the system can do to help limit this problem. Now, burnout, you can see the standard dictionary definition here. The one that pertains to us is number 2, physical or mental collapse caused by overwork or stress. A better working definition says that it's characterized by exhaustion, lack of enthusiasm and motivation, feelings of ineffectiveness, and also may have the dimension of frustration or cynicism, and I think most of us as surgeons can certainly relate to those two words. As a result of all these problems coalescing, we can be less efficient at our job, and ultimately this can impair patient outcomes. So how does it happen? I've kind of looked at this from two sides, system factors and then surgeon factors. System factors, we know that we work in a rapidly changing landscape. We know usually when there's some new program in our hospital, they really haven't been vetted through the surgeons. It's been some administrators that have decided on some level that we're going to change, things like EMR, things like HIPAA training, all of these things that keep coming at us in this never-ending mire of paperwork pull us away from the patient. There's also a decreasing reimbursement and fear of litigation. That's improved in some places, but in other places it still remains at crisis levels. Surgeons are perfectionists. We pride ourselves on being perfectionists, but that also has a downside. Striving for excellence and perfectionism are not the same thing. If you're a perfectionist, you have a tremendous, perhaps overblown sense of responsibility, breeding about self-doubt and guilt, feeling like you're not enough. You're rigid, you're unable to delegate because no one else can do it as well as you can. And all of this conspires to make you dedicated to work at the expense of self-care and perhaps with relationships to other people. And this can set off a real bad cycle where we start feeling isolated, lonely, and empty. And that's where addiction, that's where isolation, that's where a whole bunch of problems that plague surgeons come into play. When we're looking at the prevalence of the issue, it varies widely in the literature. It goes from 13 to 50%. The most widely cited studies from Mayo, it claims it's 50%. A lot of the older studies were self-reported, and they always didn't use tools that were validated in order to really quantify the amount of burnout and the nature of it. It's my opinion that the true incidence is grossly underestimated. And I asked the group, has anyone queried you about burnout, either your chairman in some written form, or a colleague, or in a faculty meeting? And the answer for me is, of course, no. So to define the problem, there is one tool that's widely used, it's validated, it's called the Maslach Burnout Inventory, MBI, and it asks 22 questions listed in 3 domains, and they've divided up into emotional exhaustion, cynicism or depersonalization, professional efficacy, and accomplishment. And it looks like this. You don't have to read all the questions, just know that they're divided amongst those 3 domains, and they get scores in all 3. You likely cannot read the individual specialties here. Perhaps you can. These are burnout rates by specialties. This tick here is 70%. This is 30%, so I'd say that's too high across the board. Emergency medicine, probably to the surprise of no one, has the highest rate. General surgery, perhaps surprisingly, is right here under the mean. So just about average rates of burnout reported by general surgeons. Contrast that with this slide, which shows satisfaction with work-life balance by specialty. General surgery being at the absolute worst, followed by subspecialty surgery. So that raises a couple of questions. We don't report burnout as much as the others, but we feel like our jobs interfere with our life a whole lot. And so I think we have less than average rates of reported burnout, but we have the worst life-work balance. I think we find our work satisfying. I think it allows us to be engaged. I think most of us still feel it's important. A lot of us would desire a more predictable work schedule with less call. And also, some general surgeons may be unwilling to acknowledge. I think there's a big denial as part of our culture, the way that we were trained. And I'm not sure that we're very good at cultivating non-surgical interest. I think in our time away from the hospital, sometimes we don't know exactly what to do with ourselves. And I think that's a problem for our specialty, maybe more so than it is for some others. So what I've tried to do in this initial part is just give us a working definition of burnout. So again, it's these three domains: emotional exhaustion, cynicism, loss of sense of professional worth or accomplishment. And what that sounds like internally is, I don't care. What difference does it make? And I suck at this. And in most places, you're going to find some colleagues that agree that you suck at it. Okay? So is it any wonder that depression, addiction, and suicide may lurk? And I only have one side about suicidal ideation, and I use it to make a few points. There was an American College of Surgery survey back in 2011. They got 7,905 responses. It was a 31% response rate, but pretty good numbers. 501 of those folks reported suicidal ideation in the previous 12 months. That's up to 3 times higher than the general population. Only 26% sought help. And more concerning, 60.1% did not seek help due to a concern of stigmatization or the effect on their medical license. That is a staggeringly concerning number to me. All of these folks scored high in the domains we talked about: emotional exhaustion, depersonalization, and low personal accomplishment. So prevalence, not minuscule. 6% of all of us. And the other scary part's the reluctance to ask for help, the fear of the secondary outcomes of trying to get help for this medical problem. So when you look at the scope, we said it was 50% across the board. But does that reluctance to report this mirror that of those that were trying to get help for their suicidal ideation? I'm saying this problem with burnout is likely to increase if strategies to combat it are not widely implemented. And I will say that most of those aspects of modern healthcare are not helping the situation. I think with each successive kind of new thing that's thrown at us by administration, I think our job satisfaction has the potential to go down. Employed model, administrative overreach, loss of autonomy, EMR, bureaucratic hamster wheel, I call it, just constant more is being asked from us from an administrative and a paper standpoint. And I think physician engagement is the key. And that's the most provocative part of this talk is at the end, and we'll talk about engagement and how that could look in the future. There is a bit of data around this. This is a paper Dr. Balch did that's been quoted widely. He looked at factors having to do with private versus academic, specialty choice, and remuneration as risk factors for burnout. He found that the highest levels were in trauma surgeons and ENTs. If you were in a pure eat what you kill mode, that was associated with burnout. Most people would like to have a standard salary that they could rely on every month, whether business goes up or down or not. Private was slightly higher than academic, and years in practice was slightly associated with burnout. The most protective things against burnout were having a youngest child older than the age of 22. Pediatric surgeons and cardiac surgeons were relatively insulated from burnout. Children of any age was somewhat protective, and the older surgeon was somewhat protective, which is kind of in contradistinction to the years in practice, but that was what the data told us. He went on to do a couple of other studies after this, looking at independent factors, first for burnout and then for good quality of life. You can imagine that they're just mirror images of each other. In this study, being male was protective. Females had a worse incidence of burnout and alcoholism in this study. Hours worked per week and nights on call per week were associated, as you would expect. And then people that had good coping strategies. This is where the self-care part of the talk is going to kick in. People that found meaning from their work, that had a positive outlook, that stressed work-life balance. All of these things were protective against burnout, as was taking vacation and discussing stressful aspects of the job with colleagues. Actually, that was not protective. And of course, if you had a regular meeting with psychiatrists, That was not protective because you already had a mental health issue. And so obviously those folks had a higher burnout. If you look at quality of life, most highly associated with having a positive outlook on things and being married. If you were compliant with the exercise guidelines from the CDC, it was protective. And if you saw a PCP annually, it was protective. Again, this idea of self-care and what are we doing to take care of ourselves is going to be a common theme as we move forward. People that were looking forward to retirement had a bad quality of life. People that still like coming to work had a good quality of life. So what I've attempted to do is take those 3 studies and kind of break down the burnout from the high quality of life things and kind of just go and line these out for us. Specialty choice has an effect. Certain kinds of specialties like trauma that lends itself to overnight call, being in the hospital frequently, we know is going to be a bit more of a burnout risk. Call frequency, we know. Depression, now is it cause or is it effect? They're so tightly linked together, it's hard to tell. I put excessive self-medication on here. This could be termed addiction. It could be alcohol, it could be drugs, it could be sex, it could be gambling, it could be eating. It could be anything you do that's unhealthy that interferes with your ability to take care of your patients. And this is isolation. Isolation is the key to all addiction. Pure incentive model, we talked about being disengaged and poor self-care. Now, you can imagine the high quality of life. They have a purpose. They exist in a supportive culture. And they do all the right things when they're not working. They exercise. They go to the dentist. They go to their PCP annually. They do appropriate screening maneuvers. They have individualized things, whether it's meditation or yoga. They have things outside the hospital that are rejuvenating rather than destructive. And they're able to cultivate relationships. The opposite of burnout, as far as I can tell, is being engaged. The opposite of addiction is having connection. And so really you have to facilitate relationships and do your best to not exist in a silo. Because when you're out there to see if you're by yourself, there's going to be no one to throw you a rope. So we've kind of identified what the problem is. The trickier part, and the part that's less described in the literature, is what do you do when you identify someone with burnout? Are there programs that can fix this? And so when we look at wellness programs, we theorize that, imagine you're in a department of surgery and you pass out the Maslow burnout inventory every year to all your faculty, and they answer it honestly, which is kind of a stretch. Maybe they will, maybe they won't. And then you have counseling sessions with those identified at risk, trying to talk to them. Maybe you have a surgical champion. Maybe you have someone who's not in the department, a counselor, someone who can sit down and kind of go over their life and see where they are with these issues of self-care and also these self-destructive behaviors. Well, I, for one, would be skeptical of filling that out. Imagine that you identify yourself as being completely burned out, and you've had some unfortunate complications the last 3 or 4 or 5, 6 months. It's not hard to extrapolate that this burned out guy is having bad complications and maybe he's not fit to take care of patients right now. And so much like we're not very good at seeking mental health, I think that could potentially be a problem if it wasn't done in an appropriate manner. And again, I think that the tools are out there to do the screening. It would really have to be used in a non-penal way for it to be effective at all. That raises the question about something called a mindfulness intervention. I didn't know what that was before I started doing this, but there's a lot of talk about mindfulness in the literature as it pertains to burnout and as it pertains to mental health. There's actually a mindfulness-based stress reduction program, and this is where it gets kind of zen and new order for me, and I apologize a bit. But it was developed by this guy at UMass, and he took 93 health providers, 62 of them were physicians from multiple fields, including surgery, and he enrolled them in an 8-week program where they went through these activities 2.5 hours a week, and they had a 7-hour silent retreat at the end of it. And they were 4 distinct activities that sound a lot like Tai Chi and meditation and things like that. There was a body scan where you focused on different parts of your body. There was mindful movement where you stretched and really focused on different parts of your body. There was walking meditation where you focused on how your body felt while walking. And finally, there was sitting meditation where you focused on rhythmic patterns of breathing to help relax and to help meditate and to help clear your mind as much as possible. They did pre and post tests using the Maslow scale that we've mentioned before. and they graded it on a 7-point Likert scale. All of them except personal accomplishment, the higher score, the worse. On this one, the lower score is worse. And here were the results. If you look at emotional exhaustion, depersonalization, and personal accomplishment, all were improved by this maneuver, by this 8-week program of mindfulness. So the conclusion was an 8-week based intervention can improve aspects of burnout in a diverse group of healthcare providers. The strongest data involved emotional exhaustion in the physician subgroup. So somehow this was rejuvenating to the physicians, and on follow-up, the effects persisted and the burnout stayed away for 15 months. So something there. It feels a little zen and hippie-ish to most of us, but something was there. So now we're going to talk about what I call systemic solutions. If there's a 50% incidence of burnout, which I try to convince you there is on multiple slides, it's an epidemic. It's not an individual problem, it's a systemic problem. And so while individual solutions can help individuals, it's unlikely really to move the meter very much. And so relatively few solutions exist at a system or institutional level, which brings us to this kind of provocative essay that was written by Colin West. He said that we're all familiar with the triple aim of modern healthcare. We talk about these three things a lot. Improving patient experience of care, including quality and satisfaction. We have press gaining out the wazoo. We're all trying to make sure the patients are happy. Improving the health of populations. We're trying to give more access, and additionally, we're trying to give cheaper health care. So the premise here is that there should be a fourth aim of modern healthcare, and it should be physician well-being. It has a measurable impact on safety and outcomes, and it should be embedded in the dashboards with all of these other metrics, and that's how you would judge a healthcare delivery system. That's how you would judge a hospital, is physician well-being would be given the same weight as patient satisfaction. Because I imagine right now, as I mentioned to Dr. Mercer before, I imagine that if a bunch of administrators were sitting in a room and physician well-being came up as something that was important, I think chuckles would erupt. I think we're the least. They think we're expendable. They think that we can be marginalized and we'll just keep doing our jobs because we're professional. And I think that gets used against us quite frequently. So his whole point is that we expand this to a quadruple aim. And it would look like this. And so all of these factors, not any single one of them, would have to be taken into account before decisions were made about how to deliver health care in that particular system. I'll tell you a personal story that's going on right now at our hospital. There is in the works a rule that every patient going to the ICU has to be seen by a faculty surgeon within 2 hours, and every patient being admitted to a floor bed has to be seen by a faculty surgeon in 4 hours. We have lots of services, and we have lots of residents, and we have lots of people coming in at midnight that are going to get operated on at 6 or 7 the next day that aren't going to be seen in 4 hours, if not for this rule. I propose to you that if we cared about number 4, that rule probably wouldn't pass. It's likely going to be given to us without any consideration of this, which is going to create lots of headaches for lots of folks. So in summary, I would say burnout is an increasingly recognized issue among physicians and other healthcare providers, 50% plus. Doctor factors and system factors conspire. It can be measured with validated tools. We've proven that. And we should screen for it. I think prevention is going to likely be more effective than treatment, although there is novel work ongoing. Self-care, engagement, and connection are key. We have to take care of ourselves and each other. And finally, I think the most important and perhaps the most far-reaching thing was if we could truly make this a quadruple aim and really have as a metric on all hospital dashboards, along with financial performance, along with patient satisfaction, have physician well-being be just as important. So I'll finish with saying that most of us still love the art and craft of surgery, but we have to prioritize self-care, and we have to use the precious time out of the hospital for rejuvenation in order to take the best care of our patients. And with that, I will say thank you for the honor, and I really appreciate it.